Japan. Professor Shiina, please.
So it is a great honor for me to be given Powell Sarin Achievement Award. Since I graduated from my medical school, the University of Tokyo, I've been working in the field of image-guided tumor ablation. First, ethanol injection, then first-generation microwave ablation, then radiofrequency ablation, and recently, new generation microwave ablation. So today I'd like to talk about ablation for hepatocellular carcinoma. Primary liver cancer is the second leading cause of cancer-related death worldwide, and the incidence is increasing steadily. And currently, 80% of the primary liver cancer is Asian, found in Asia-Pacific region. The most common type of primary liver cancer is hepatocellular carcinoma. So the only 20% of HCC patients are candidates for surgical resection. Furthermore, recurrence is frequent even after curative surgical resection. Liver transplantation plays a limited role because of the donor shortage. Due to the limited role of surgery, various non-surgical therapies have developed. Among them, image-guided percutaneous ablation is regarded as best in the treatment of early HCC. So ablation includes ethanol injection, radiofrequency ablation, microwave ablation, and others. Ablation is potentially curative, minimally invasive, and easily repeatable for recurrence. Ethanol injection was first reported in 1980s by Chiba group in Japan. And our 20-year outcomes show that ethanol injection was potentially curative for HCC, resulting in survival for more than 20 years. Radiofrequency ablation was first introduced in Japan in 1999. Radiofrequency ablation has been the most widely used ablation techniques for liver tumors. And our randomized controlled trials and others have demonstrated that radiofrequency ablation is superior to ethanol injection. This is our second case of RFA. 48-year-old man was found to have a lesion of 3.6 centimeters adjacent to infravena cava in February 1999. And this is a CT scan after RFA demonstrated the entire tumor necrosis. Some doctors may say that RFA cannot ablate the tumors adjacent to large vessels entirely because of the heat sink effect. However, our second cases of ablation show that if we perform ablation skillfully, complete ablation can be achieved. Regarding the short-term efficacy of anti-tumor effect of RFA, complete ablation was achieved in 99.4% of the treatment in our early study. And regarding the long-term survival, this slide shows the survival of 1,616 patients who underwent RFA for primary HCC. The survival rate was 62.3% at 5 years, 28% at 10 years, and 15% at 15 years. And now, new generation microwave ablation, incorporating antenna cooling and high power generation have attracted attention. I'd like to show a demonstrable case. This is an 80-year-old man who was found to have a 4 centimeter HCC beneath the diaphragm in segment 8. And we performed microwave ablation with the artificial ascites technique. CT a day after ablation showed the entire tumor necrosis. And this slide shows the number of cases treated with radiofrequency ablation or microwave ablation in our institutions. Now, we have performed more microwave ablation than radiofrequency ablation recently. So many high-volume centers of ablation in Japan and in Eastern Asia have introduced new generation microwave ablation for tumors. And I'd like to talk about the competition with surgeons. Since the ethanol injection period, we have had strong argument regarding which treatment is superior for HCC, surgical resection or percutaneous ablation. So in Japan, we conducted SAF trial. We conducted a multi-center randomized controlled trial to compare surgery with RFA. 48 major centers in Japan enrolled patients with good hepatic function and HCC of 3 or fewer nodules, each 3 centimeters less in diameter, during the 6-year period of 2009 to 2015. The 308 registered patients were followed for at least 5 years. And this is the final result of the SAF trial. So the final result of SAF trial was announced in 2021. It revealed that overall survival and recurrence-free survival were not different between surgery and radiofrequency ablation in HCC of 3 or fewer nodules, or 3 centimeters less in diameter. And this was the previous Japanese treatment algorithm. So resection was placed above RFA, indicating that resection should be a priority. However, as a result of SAF trial and others, the revised algorithm in 2021 treats hepatic resection and ablation equally for patients with HCC who have 3 or fewer nodules or 3 centimeters or less in diameter. And this slide shows a comparison of scars between surgical resection and ablation. Ablation is a minimally invasive therapy which does not require general anesthesia or laparotomy. Ablation is performed on patients of advanced liver cirrhosis or advanced age. Now I'd like to talk about pharmacotherapy and ablation. This is a treatment algorithm for HCC by APASL 2017. Ablation is used for early HCC as potentially curative treatment, but ablation cannot be indicated for advanced HCC. Pharmacotherapy is used for advanced HCC, which cannot be treated by either surgery or ablation. And the combination of ablation and pharmacotherapy may build a new treatment strategy. I would like to show a demonstrable case. This is a 72-year-old man with taste refractory HCC treated with lenvatinib and ablation. He underwent hepatectomy once, and then he underwent repeated TACE. But after 6 times of TACE, he was judged refractory to TACE, and he was referred to us. October 2019, lenvatinib started. This figure shows the condition before we start the lenvatinib. The largest tumor is 70 millimeter in diameter, and he had 5 other tumors. This is a CT scan. The largest tumor, 7 centimeter in diameter, was continuous with the inflamed vena cava, and he had 1, 2, 3, 4, 5 other tumors. A total of 6 tumors he had, at least. And after 12 weeks of lenvatinib, the largest tumor lost vascularity and shrunk. from 70 millimeter to 56 millimeter. However, hypervascularity remained in 3, 2 enlarged and the other unchanged. So on January 2020, we performed microwave ablation for the 3 tumors with hypervascularity. And 3 months later, April 2020, we performed the second microwave ablation for 2 other tumors, which showed hypervascularity by contrast-enhanced ultrasound. And this is a CT MRI taken on June 2022. We stopped lenvatinib 2 months after the second microwave ablation. For more than 2 years, he has not received any treatment for HCC, not either pharmacotherapy or ablation. We have 21 cases in which the combination of pharmacotherapy and ablation has achieved complete response. So we think the combination of pharmacotherapy and ablation may build a new treatment strategy. Incidentally, ablation has problems because ablation appears a relatively simple procedure that some doctors may perform ablation without sufficient training. And ablation is possible to be performed even with inexpensive, poorly performing equipment such as ultrasound. Thus, ablation may be performed under inappropriate circumstances in some institutions. In order to raise the level of ablation as a whole, we held ablation training programs. Programs are composed of comprehensive lectures, live demonstrations, and case studies. The context of lectures include current status of ablation devices, ultrasonography, and others. And we perform radiofrequency ablation or microwave ablation on 3 to 4 cases per half day using artificial ascites, artificial pleural effusion, contrast-enhanced ultrasound guidance, and fusion imaging method. In the 5-day program, you will be able to see 12 to 15 cases of live demonstrations. In case studies, difficult to ablate cases from participant hospitals are presented and discussed. This slide shows a total of 237 participants in the 1st to 14th domestic ablation training programs. And this slide, we also have the international training ones. And this slide shows the 111 participants in the 1st to 7th international ablation training programs. Before the pandemic of COVID-19, we had the domestic and international training programs for intermediate and advanced doctors and ablation club for young doctors. These were activities to disseminate skills and know-how for ablation. However, after the pandemic of COVID-19, we are not able to hold on-site training programs. To overcome the situation, we have started domestic and international ablation webinar. The domestic ablation webinar, a total of 1,566 participants. And we have also held international ablation webinar 4 times, and the total of 1,278 doctors participated in. And so now the pandemic of COVID-19 almost ceases. So we will restart the domestic and international ablation training programs in the near future. And we established in Japan Academy of Tumor Ablation last year. There are some triggers. One is that SURF trial revealed no differences in overall survival and recurrence-free survival between hepatectomy and ablation. Another is that ablation for lung, bone, soft tissue, and kidney cancers has become reimbursed in health insurance from September last year in Japan. And in 2021, we had the ACTA meeting, Asian Conference on Tumor Ablation in Tokyo, which also served as an impetus for the establishment of Japan Academy of Tumor Ablation. This slide shows the number of JATA members. So in Japan, 68% of the members are gastroenterologists or hepatologists, 18% radiologists, 6% surgeons, and the remaining 8% paramedics, business associates, and others. So in summary, SURF trial and others revealed that overall survival and recurrence-free survival are not different between surgical resection and ablation. Combination of pharmacotherapy and ablation may build a new treatment strategy for advanced HCC. Cure can be achieved in some selected cases. Education is important to train future generations. Ablation is expected to play an increasingly important role in an aging society. Thank you for your attention.
Thank you very much, Professor Shiina, for your excellent lectures.